Good morning, everybody. Welcome to Peter Mac if you're in the building, and welcome if you're online. My name's David Speakman. I'm the Chief Medical Officer here at Peter Mac. And yes, I am operating on the side, not while we do this session though, hence the scrubs. So I'm very happy to welcome you to the ground round today, caring for our carers, how we're supporting this vital component of cancer care. And I think it's something that is often forgotten way too much. In cancer care, we're focusing on the patient all the time and not necessarily think about those around them and how the ripples, as you all know, the ripples of cancer just go out and hit everybody as people go through the journey. So just want to start by thanking the traditional owners of the land on which we meet. If you're here in Parkville, that's the Wurundjeri people of the Kulin Nation. And I'd just like to pay our respects to our elders past and present. I'd also like to welcome any Aboriginal or Torres Strait Islanders who are joining us here in the room or indeed online. So we're very lucky to have Gail Ewing out here, Dr. Gail Ewing, all the way from the UK. She's been a Senior Research Associate at the Centre for Family Research at the University of Cambridge, and also holds honorary positions both at Cambridge Uni and Manchester Uni in the UK. She's got a long track record in social science work and nursing, and more particularly lately she's been focusing on complex interventions and how we can implement them into practice. And then I think she's sort of then moved on to patients with long-term chronic conditions and helping the carers and families of those patients as well. She's the co-developer of the Carer Support Needs Assessment tool, intervention that's called CSNAT-9, with Professor Grand from the University of Manchester. And so to support the implementation of that across not just the UK, but as you'll hear in a minute, in Australia and around the world, they've developed an online training and implementation toolkit to do that. And we'll probably talk a bit about that today in Gail's talk and also on the panel. So we're hoping Gail's going to talk to us now about embedding cancer assessment and support into routine care, because I think hopefully that's where Peter Mac is up to. And Gail's going to explore some of the barriers and enablers she's found to that across the globe. Thanks very much, Gail.
Bit dry with the masks. Well, thank you very much for inviting me today to talk about caring for our carers. They're very much a vital part of cancer care, so it's great to have a focus on them entirely for this session. I wanted to start with an outline of what I'm going to cover today. I'm sure I'm talking to the converted here, but I just wanted to touch a little on the importance of supporting family carers, and then briefly look at the policy and practice realities for carer support. Then I want to look at some key messages that we've learned on how we might better support carers, arising from a programme of research in the UK that I've done with Professor Grand at the University of Manchester on palliative and end-of-life care that's very much encompassed the work of working with cancer carers. And finally, to focus on a study that we've done in which we identified a set of recommendations for organisational structures and processes to better enable carer support in routine practice. Now, repeated evidence shows us that carers are a main factor in patients being cared for at home and for them achieving their preferred place of death. And we also know that carers provide many hours of care and attention. And in the UK, my colleague Gun Grand completed a recent national census survey of cancer carers in the UK. And in the last 3 months of life, when caregiving is very intense, they found that carers contributed an average of 69.5 hours of care per week. And so if you think about that, that's something like 10 hours per day, 7 days a week. So it's quite substantial. The main type of care provided was social and emotional support. And the majority reported contributing to very practical tasks of everyday living and to the medical care of the patient. And those who helped with personal care spent a high number of hours in their caring role. Now, we also know that caregiving comes at a cost to carers in terms of their own health and well-being. And again, from this National Census survey of cancer carers, it was found that 83% of cancer carers suffer clinically significant psychological morbidity in the patient's last 3 months of life. And this compares to 15% with psychological morbidity in the general population, as measured by a health survey in England. There's also an impact on care when carers can no longer manage to cope. Quality of care for patients is affected, and there's a substantial proportion of inappropriate hospital admissions are carer initiated or arise when there's breakdown of caregiving at home. So how are we currently addressing this impact on carers? Well, health policy has long recognised the role of family carers in both Australia and in the UK. And I've been looking at the Victorian Cancer Plan and the Victorian Carer Strategy and the end-of-life care and palliative care framework. And these documents, in these documents, carers seem to feature heavily, with the cancer plan stating support for the carer strategy and a commitment to building workforce knowledge and skills in relation to carer support. And it'll actually be quite good to know how you find that this works in practice. And in the UK too, given the impact of the caregiving role, recognition of the need to support carers has also been manifest in health policy. However, over the last 15 years or so, there's been a subtle shift from what was an explicit focus on carers and their needs for instance, in the guidance for cancer services or in our end-of-life care strategy. And it moved to a focus where it's much more jointly on the patient and carer together. And this was done with a good purpose of better integrating services for carers in a healthcare context. But I think the actual effect of it has been to relegate carers to much more of an add-on position. And there's been a loss of recognition of their separate situation and their separate support needs. So currently, in a health context in the UK, we have policy ambitions, and I've put ambitions in inverted commas on purpose, and they provide a framework for local action. And these ambitions are things like each person is to be seen as an individual. It's about having honest conversations, and this is something that's very important, to be talking about what is important to you, but also about systems for person-centered care. And these are all laudable ambitions, which are not meant just for patients. They are intended for carers too. But in the UK, these very much remain ambitions. They were first published in 2015 as a refresh of the end-of-life care strategy. And then they were reissued again in 2021, as they were still seen as very much works in progress. And I think we're still in the same situation now. Now, the practice realities for carers can be quite different to these ambitions. And there's certainly a strong ethos of supporting carers in the United Kingdom, where services aim to be there for the carer and family, but patients do remain the main focus. And things for carers were hugely difficult during the pandemic. And services in the UK are only just now starting to return to some kind of normal. Support for carers can often be through ad hoc conversations, taking part on the doorstep where care provision is at home, or in busy hospital corridors. And these are informal conversations. We're frequently told about picking up cues and sensing things where carers are concerned. And they tend to be practitioner-led, where clinicians raise issues when they feel it's appropriate. So thinking about how we might do this better, I want to tell you a little bit about the program of research and implementation studies that I've worked with Professor Gundgrand, who you can see here on the slide, at the University of Manchester. And these were studies about supporting carers in everyday practice. Now, we've learned a lot from these studies, and I'd like to share with you some of what we've learned. So first of all, 3 key messages about carer support. And this is message 1. The first is that carer support needs to involve both their carer roles. So this is carers as co-workers to enable them to care for the patient. But they need to be supported as carers in their client role. So more direct support to them with their own health and well-being while caregiving. And carers are a very valuable support, a resource whose expertise needs to be recognised by professional carers. The professional care team, I should say. However, in our work with carers, it's very clear that rather than just be treated as co-workers, they often need support in this co-worker role, especially when the patient moves towards the end of life and things change and become less familiar. And of course, they need more direct support for themselves as individuals in their own right in terms of their health and well-being. And comprehensive carer assessment and support has to encompass both sets of needs. The second message is that a formal process of assessment and support is needed. So not just these informal chats in corridors or on doorsteps, for carers to feel it's legitimate to ask for help, but also a formal process that ensures visibility of support needs, because carers most often have not been in this situation before. So a formalized process gives them permission to ask for help. And the third key message is that assessment and support needs to be carer-centered. Carers themselves need to identify what's important to them as individuals if we are to achieve tailored support for carers. So there's not a one-size-fits-all approach where there's a common set of supports that can be offered. And key to assessment and support being person-centered is actually to ask carers, because practitioners can get it wrong and actually can be surprised what comes up when carers themselves are asked. And this quote from a practitioner reflects a very common experience of practitioners that we've found. What I found particularly useful when using formal carer assessment was the things I thought the carer might not be able to cope with were the things she was coping with. And the things she wasn't able to cope with, I was quite surprised. And this is a message that has come through over and over again in our studies, that the importance of the carers being asked what's important to them. So therefore, these are important lessons to have learned. But to make a difference to carers, we need to think about and consider how we can embed these lessons into routine practice. And if we want to make a difference, organizations need to rethink how they work with carers. Now, this was a study where we looked at organizational structures and processes that need to be in place in order to provide comprehensive person-centered carer assessment and support in routine practice. And you can download a copy of this report from the link here. So this was a multi-perspective mixed methods study, a secondary analysis of a rich data set on implementation of carer assessment and support across 36 different palliative care organisations in England. And these were hospice day services, community and hospital-based palliative care teams, and district nursing teams. We conducted focus groups and with senior practitioners and managers who had experience of delivering person-centered carer assessment and support in their practice. And we also conducted a wider stakeholder consultation using workshops and a survey with different health and social care professionals, carers themselves, policy leads, and academics. And the outcome of this piece of work was 10 recommendations in all. The first 4 you see here are the core recommendations, basically the baseline that needs to be in place to begin to deliver comprehensive person-centered carer support. The other 6 are a set of recommendations about what's required to successfully implement and sustain this approach in practice. And I'm just going to take you through these as we go along. So first of all, consistent identification of carers within the care setting. Seems very obvious, but it doesn't always happen. But we need a systematic and consistent process. And the key word here is consistent, because not all carers are identified within the care setting. It needs to be a proactive approach by practitioners themselves within the organizations. But it's also very important to be aware that carers themselves don't always identify with the word carers. It can be quite a loaded term, preferring to see themselves in relational terms. But this doesn't need to be a barrier to identification and support. We can quite simply ask who gives the patient most care and support. We don't have to use this word carer that can be something that is rejected. The second recommendation is about demographic and contextual data on who the carer is and their situation. And this is to aid awareness of carers and to underpin assessment and support. And certainly in the UK, we have a lack of data on carers. And one of the workshop managers provided this quote, and she said, well, it's interesting because I'm always asked how many carers we're supporting. And everyone knows how many patients were referred in the last year, but we have no data on exactly how many carers we're supporting. So systems need to be put in place across all settings. The third recommendation is about a protocol for assessing carers and responding to that assessment. So moving away from that informal practitioner-led approach to a more carer-centered process, because current processes tend to be inconsistent, quite narrow in focus, and a bit ad hoc. We spent some time working with a senior practitioner from St. Christopher's Hospice, and he told us that he had a team of very experienced social workers, and they all had a favourite issue that they discussed with carers. And so there were all these separate little assessments that were very narrow in focus to the individual practitioner and what they were happy with. And as he put it, it was fine if you had emotional and psychological support, and you had a social worker that was going to focus on that area. It was pretty hard luck if you got that social worker and you had issues around practical issues instead, and equipment. So it's about bringing into place a consistent and a comprehensive process, and one that also recognises and values the role of carers. And with this, at the most basic, we need a recording system for carer information to support the identification of carers and underpin that assessment and support process. And certainly in the UK, this is a significant challenge across all settings. Where do we write up the carer assessments? Where there are carer records, and there are increasingly starting to be some options for carer records, particularly in the hospice sector, there needs to be consistent completion. And that doesn't always happen. So these four are the core recommendations, I would say, the absolute basics that need to be in place. But there are other structures and processes that are required to support implementation in practice and to sustain it as well. So a process of training for practitioners, because comprehensive person-centered carer assessment and support represents a significant change in practice away from the informal processes I mentioned earlier. And the training really needs to be at multiple levels. Just at the very basic, again, a general awareness raising of carers and their need for support across the workforce. As part of practitioner training for nurses and allied health professionals, but a particular focus on training for junior frontline staff to identify, assess, and support carers in their day-to-day practice. But again, the stakeholder workshop made clear that training applied at the level of advanced practitioners as well, as they put it to up their game and provide a level of support for carers in their everyday practice. And a fundamental issue is available time and workload capacity for carer assessment and support. It really is a fundamental issue for organisations. Practitioners in the study who were experienced in implementation and practice described the investment in time in the short term was worth it for later gains. It had the potential to improve quality of care and provide better outcomes for carers, which had a knock-on effect to better outcomes for patients. And at the time we did the study, the stakeholders told us that frontline staff were firefighting in terms of time to spend with carers. I think that situation has got worse with COVID and the pandemic in the UK. And what they were very clear about was that positive sentiments about supporting carers weren't enough. There had to be an addressing of resource issues to enable this to actually happen within the workforce. But they also said that it wasn't just about time and resources. It needed a considerable mind shift for practitioners from a focus just upon patients themselves, as was said in this introduction. Support from senior managers, again, is absolutely necessary to initiate that change in practice at the very beginning, but also to drive the process forward. Because without that support, none of it happens, but also it doesn't happen and sustain in the longer term. And crucially, that's important. So there's the need for some kind of dynamic input, because if you don't refresh the vision, the initiative won't keep gaining. So it needs to come from the top, that it's supported in day-to-day practice. And this can be very much helped by having role models or champions for carer support in practice. But again, what our workshop participants, our stakeholders, were very clear about was that this isn't just giving someone a title as a carer champion, but actually organizational investment in the role, enabling champions to have the time to work through all these different roles. And pathways to communication is absolutely necessary for successful implementation in practice. And by this, we're meaning two-way communication between organizational levels. So from the senior management up at the top, saying how they want carer support to be developed in the organization. But it's not just a top-down process, it's a bottom-up process as well, where practitioners who are delivering the support on the ground, particularly using this change in practice to a person-centered approach, have the opportunity to feed back their experiences to the senior management and have any concerns or difficulties addressed. Communication, obviously, between peer practitioners as well, but also that communication is actually specifically about carers in their own right. They can sometimes get mentioned, but this is an area where we have seen some progress in the UK to a number of teams who now include a report on carers in the MDTs. So we talk about the patients, but then talk about carer support as well. And finally, procedures for monitoring and auditing process and outcomes. And these can be for internal purposes to see that goals have been met and any problems identified, but also for external communication. You want to be telling people from outside the organization what's happening. And in many cases, it can be a really strong motivator to gain extra funding and to tell commissioners about what is being achieved in practice. So these were the key recommendations, and we see them as building blocks to turn policy ambitions for better carer support into everyday practice. And the report that we did ended with two key challenges for organizations, and one being the general challenge of embedding a different way of working, person-centered care, and that can be particularly difficult for carers. And there is a move to spend more time looking at change management to bring this about. But we also felt in the UK there was a carer-specific challenge of resolving where carers fit within cancer services. And we find that that is a huge discussion point. In the UK, it's a really big challenge, and in training sessions we do about organizational issues. we usually ask services to start thinking about whether they have a mission statement for carers or do they have a strategy for carers. And actually very few do. And nothing like this strategy that I've been reading that you have at Peter Mac, and which I intend taking home as an exemplar for practice. I'm very interested to discuss how this strategy has enabled you to better support carers. So just to end, carers are a resource we need to sustain. They're a vital resource in cancer and palliative care. And unless we support them to support the patient and to look after their own health and well-being, both patient care and carer health are likely to suffer. Thank you very much for listening.
Thanks, Carl. It's fantastic. Very interesting. Made sense of a whole lot of things Jerry, the wellbeing team, talk to me about all the time, which is great. Fantastic. Could I get the panel to come up out the front here, everyone? So we're going to have a bit of a panel discussion now. So please, if you have questions, if you're in the room, if you just raise your hand. So we'll bring a mic just so people online can hear. And if you're online, like it's on Zoom, so the Q&A section, if you just type in any questions you've got, apparently they will come up on a screen. And Jerry McDonald has already sent a question from her sick bed. Hi, Jerry. I hope you're feeling better. She's been off and had surgery, but now got the respiratory infection. So might just start by introducing all the panel. Gail, you've just heard from. Catherine Ewan has been volunteering at Peter Mac since 2017, and she cared for her father and her husband with both with cancer, and tells how those experiences have changed her life. She's developed a passion for researching all matters related to cancer during her husband's fight, and we're lucky she's joined the team in the Australian Cancer Survivorship Centre to build on her knowledge and use it to help other people. So it's fantastic. Welcome, Catherine, and thanks for your time. Ella Sexton's up there. She's a clinical psychologist who's worked in the POP, it's a psycho-oncology program here at Peter Mac for ages, and very invested in helping loved ones adjust to the emotional and psychological challenges of cancer. She's got a special interest in working with families, and indeed joined our carer support program last year, and she's supporting our carers as best she can at the moment. I think one of the things we'll get to is the resource required to do that, because she can't do it all on her own. Not that she's not getting help from all sorts of people. Tegan Murnane's probably well known to many of you, a senior social worker here at Peter Mac, and worked with carers and patients for a long time, 13 years. I was going to say it must be longer than that, Tegan, but I'd get in trouble with it. I've known Tegan for a long time. Been lucky to know her for a long time. She's worked on many projects focusing on developing on optimising supports and pathways for oncology patients and their carers, in particular around geriatric oncology. She's just completed a graduate diploma, actually, and that's fantastic. And last but not least is Celia Marston, who's running occupational therapy here at Peter Mac at the moment. She's also the research lead for allied health at Royal Melbourne Hospital, and squeezing in a PhD at the same time, just for good measure. She's contributed to a lot of the studies in rehab and complex interventions in oncology and palliative care. And in particular, that's included a couple of the projects that Gail was mentioning. So the CSNATI at Peter Mac and Royal Melbourne. And she's the chief investigator in the CareNet trial, which is a phase 2 feasibility trial testing whether that tool helps assist patients and carers during discharge from Peter Mac. So without further ado, I might start with Jerry's question, which is first, ladies, do you think working with carers should be part of usual business or a separate program for people with expertise around assisting carers? So I suppose it's, do you need to have a carers program per se, or are we at the point of putting carers support into business as usual? Who wants to have a crack at that?
Okay. So my experience as a carer, it's been a tough one. Even though I went through it with my father 20 years earlier, my husband unfortunately had quite a difficult journey. And so there were lots of complications that came up constantly. I was always reacting and I wasn't able to plan ahead for anything. I think I was given a whole lot of booklets and information, but frankly, at the time, unless it's got anything to do with my husband's conditions and what I can do for him, I just simply didn't have the time to look at any of it. And people would probably ask me, do you need help with anything? But, it's a very ad hoc thing. And if I get asked that, usually is whatever is, happening at the time. And so very reactive. So I was really happy to be part of the program to roll out CISNET at Peter Mac. First of all, I have to say it really surprised me that was being rolled out by a hospital, because I was always under the impression that hospitals is for patients and not necessarily for carers. So it was a big surprise and very happy to see that. Secondly, the assessment was amazing. Having exposure to the assessment showed me that there were a number of things that I needed at the time, but I actually just didn't have the headspace to think about it. So having a formal framework and being able to think through all of the different elements would just be an amazing opportunity. And one thing more that I would just like to say is, for me personally, I think even if the help wasn't readily available, just going through the process and actually being able to think about what I might need help with is a really good start, because at least it allows me to take that information to go away and plan ahead. And even if I can't deal with it myself and I can't get the help readily, at least I know to go and look for help somewhere else.
So it sounds like CISNET helped you, at least you pick out things you may not have considered, and then you could then try to manage that. Yeah.
Yeah, definitely. I mean, if CISNET had been around when I was going through the process with my husband, I think it would have helped me greatly, because it had elements in there that I had never even thought of at the time.
Harks back to that quote, I think, that Gail had no talk about. You don't know what you don't know.
Yeah.
Do you think any particular things, given your experience, besides something like CISNET, that might have helped you, that you think we could do?
I think just taking a little time and having a conversation with us about what's going on and what's to expect, that was the hardest thing for me, because not having gone through that process before, and because my husband's condition was changing so quickly, I just didn't know what was around the corner. I didn't know what to expect, and I couldn't plan anything. So I would have really appreciated it if somebody could have actually sat down with me and say, this is what's happening. This is what's likely to happen in the future, and here's what it might involve. So I can at least start thinking ahead and plan out, what I need to do and what help I might need to seek. That information would have been really powerful. And that was something that I was sorely missing at the time, because I didn't know what was going on. So I was just constantly reacting. And I was under a lot of stress as well, because by nature, I'm a planner, I'm a project manager. I even Gantt charted my own wedding. So for someone who couldn't plan, and couldn't see what's around the corner and constantly being caught off guard, that was very difficult.
Thank you. So maybe Ella and Tegan, you're on the floor from the hospital side. What things, you sort of know where we're at. What things do you think we need to do to change to embed this type of thing?
Yeah, I think it's quite difficult working in a system that's working under a medical model that is really patient focused. It's really hard for carers to get the time and support that they need. And I think that a lot of that, as you've both said, is around that permission. We don't sit patients down and say, come into an appointment and say, what do you want what treatment do you want? What do you want me to do? We give them the information, we provide information for them to give informed consent about what they would like support with, the options for their treatment. And I think it's trying to kind of mirror that with our carers and being able to sit down and say, look, whether that's through the CISNAT tool, through early assessment with social work and other allied health, but saying that these are the options that you could have to support you. Now you tell me what's actually important to you and what you might need through that. And I think having a carer specific service, as Jared sort of put forward, would be something that would be really useful, because I think that is another indicator that you see a sign for a carer service, you see a message on the internet that shows our carers at Peter Mac that you're important. It's okay to ask for help. That's normalising needing that support as well. So it's not as scary to ask for that help. So I think a lot of it is just being able to normalise the processes, have it part of everyday conversation that this is a support that we expect that you need, but also making sure that carers have the voice to be able to make those decisions for themselves as well.
And I guess I've been lucky enough to be part of the carer service. And as Tegan said, it's fantastic for the visibility and for carers to know that we recognise that they have needs and that there's a place that they can go. So in our carer support program, we've got Cassie, our carer support officer, who carers can drop into the Wellbeing Centre and talk with. And I'm there one day a week providing some psychology support for carers. And so it's sort of by having a program and a space that carers can come to, it puts control into their own hands, or having that autonomy to reach out when they need support. I think that's something that's really fantastic and new at Peter Mac.
Thanks. So maybe I'll just throw to Celia and Gail. There's a question from the online audience. Love to talk, Gail. Thank you. Very interesting. Is there a strong evidence base regarding which interventions best relieve carer distress in cancer?
I guess I only have a portion of experience to Gail, but I can speak perhaps in the practical sense of the trial and the work I've been doing here at Peter Mac, and listening and interviewing a lot of carers and finding out what is important and what helps them feel better. And in terms of, as Gail said, there's huge risk of distress and occurrence of distress for carers, and my work's particularly around that point of going home and preparing for someone to go home to care for them. And I think what I guess has been recognised is that ability to have someone actively listen is an intervention in itself. And I think the CESNET has been a formalised structure to do that, and I'm sure there's other structures to do that, but that, the interviews of patients is, it validates it, carers, it validates it for me. My, things that I thought I didn't know I could cope with, I can cope with, or things I was unaware of, I now know, similar to Catherine. And I think there has been links around that sense of, in other research, that sense of if someone has good self-efficacy, feeling in control, and that will correlate with less distress and better well-being. So I think even just that starting point of actively listening and having someone work through what their needs are and then addressing their needs is a really good start.
Yeah, I would say there are different psychological interventions that you can target carers with, and it will reduce their distress. But in relation to the previous question, I would say that it should be core business for all, and really picking up on what both Catherine and Celia saying, to give all carers the opportunity to have the chance to talk and just be listened to is such a powerful intervention. There was a trial done in Denmark a few years ago, again with the CESNAT, and it was shown to reduce carer distress. And I think the issue for us is that the opportunity to use something like the CESNAT intervention, which is really for all carers to have that chance to have a conversation with a practitioner, I think is quite a powerful thing. And actually, the sort of things you were saying, Catherine, I think I'd quite like to take you home and have you sit on a platform in the UK, because exactly that opportunity to talk with someone at a time where you have no idea really what's round the corner. One of the questions on the CESNAT is, do you need more support with knowing what to expect in the future? And that is a phenomenal conversation starter. Many practitioners, I'm told, find it quite hard to start a conversation with carers that are particularly getting very close to the end of life. Whereas that question, it doesn't say we're talking about end of life care or anything like that, opens up conversations. And it's actually across the different trials we've done, has been the question that comes up as the one that most carers want more support with. And it's a brilliant conversation starter, because it can go in whichever direction the carer wants it to go with. And you would have had the opportunity to say, well, you know, I don't know what's happening next. And I think that's a very powerful thing.
Thanks. It probably gets an excellent question on that from the online from Jared, saying we've mentioned many carers are resistant to identify themselves as a carer. Yeah, has the panel got suggestions or advice on how we can encourage the resistant carer to take up the sort of supports and services we have around? And clearly, introducing them to the idea of CESNAT is a great one. Any other strategies to get those resistant carers to be aware of what we can offer them, or indeed get them services they might use?
I think often it's also just asking people the question directly as well, and saying, look, if, you know, we often use the language around carers and what carers need, but, you know, can you tell me what you kind of identify your role as, or what's important to you too? And I think sometimes when I'm talking to people who are providing care, it's often them sort of saying, well, I just do it anyway because I'm their partner or I'm their family member. And it's sort of acknowledging too that that's not, you know, something that is expected or is necessary or is something that people can do all the time. And when it is looking at something like 10 hours a day of care, there is not a service that you can get without huge financial backing that can replicate that. So it's a huge undertaking that people just sometimes don't acknowledge themselves. And sometimes that's where being able to have it quite clearly acknowledge that carers are important, and having, you know, the strategies in place and the services that shows people that, oh, this is something that a lot of people are doing and it is recognised. But I'll often talk to people too about, you know, if you came in and broke your arm and someone said you need to put a cast on and you need to take this medication, you need to go and fill this prescription, people do that. And that it's kind of looking at that in another way too, and saying, you know, your prescription's actually to look after yourself and to do this and to get support for the things that you need help with as well, and to see it as actually part of the patient's treatment as well, so that they are able to do that. Because I think if people are used to looking after everyone but themselves, it's very hard to put your hand up and say, I need the help myself now. So sometimes it is saying that, you know, having to reframe that in terms of, like, if you help yourself and you're getting support for yourself, you're actually able to provide that care more readily and be in a better place to provide that care for the person that you care for and that's important to you as well.
Just while you've got the microphone taken, just carers allowance, do we think, is there such a thing, and is it easy to access? Could we be accessing it more? Because as you've said, these people are doing a second job really most of the time. You know, 10 hours of the day, you go to work for 8 hours and come home and look after your family member for 10 hours. What sort of stuff's around, and is it easy to get? Or to Medicare make it a nightmare?
I'll try my best to summarise the trials and tribulations of Centrelink briefly, but There's a couple of Centrelink carers payment. There's a carers payment, which is a full-time pension if someone's providing full-time care. There's a carers allowance if someone's getting about 8 hours a week of care. The carers payment's quite difficult to access. That's financially tested, that's means tested. There's a lot that goes into it and it's not a huge amount of money. The carers allowance, I would encourage anyone who's providing care for someone to look at applying for. That's on top of a full-time wage, on top of any other pension. It's about $152, I think, a fortnight. So it's not a huge amount of money, but that is something that can help with transport costs, with, you know, bits and pieces, extra help around the home and things as well. But it's a lot of paperwork and it's at a time when people are least feeling up to doing that as well. So it is quite difficult to kind of navigate that too. So they're the things as well that people aren't aware of, and they're the things that we need to be talking to people about, that they can look at accessing. And that's part of our job and our responsibility, to be able to say to people, look, these are some things to consider. So it's just sort of helping them navigate that process and trying to take some of the burden off where we can as well. But Centrelink's never a straightforward, easy process, unfortunately.
Yeah, I think that's part of my point. Perhaps we need to work, not you, perhaps we need to work on making that a bit easier for people, don't we? Excellent. Any other comments there? Maybe I'll jump to another question. Or was there a question in the audience? Sorry, Dave.
Hi, I'm David. I'm a consumer member here at Peter Mac. It's fantastic to hear everyone's story, and I was a carer as well, and a great body of work, Gail. My question is open to the panel. I'm listening to all the great work, and I think if we lined up 100 patients and carers, they'd all be thinking, wow, we're really at the forefront. What would success look like, and what do you need from us to achieve success?
I'll tackle this one first. I think success, and I think it came up in Gail's talk around those recommendations, is that inclusiveness of carers, of all carers, and I'd say that the time points, providing the support at the time points that are important to them. And it seems like a big, idea in a hospital or health system that's under a lot of pressure and resources, but I guess the earlier and the most timely impact that we can have on carers, the better. That we're not missing those points of crisis. And there's I've interviewed a lot of clinicians and occupational therapists mainly, but in terms of, we're often on the corridors looking for ad hoc moments or entry points, but that's kind of our assumption. So I think if we can, be inclusive of all carers, that's a really, really good start. So I might move on to someone else.
I think that's a really good question. Yeah. The elephant in the room always when we talk about those 10 recommendations is available resources and workload capacity, because certainly at home we have this dilemma where organisations will say we support carers, and then they decide to implement the CESNA intervention, and then they say, we haven't got time for this. Well, if you were supporting carers before, how come you don't have time for this now? And that whole thing of senior management support, role models or champions, and that being resourced, but actually looking at the resources for carer support in the organisation. If that would be success for me, that there were more resources dedicated to that. I'm not wanting to take anything away from patients, but we know how much work these carers do and how important it is for them to be supported. And if they're not supported, things fall apart at home particularly, and then patients can end up in hospital when they don't want to be here, even a lovely hospital like this one.
I think you're absolutely right. The win for a health system is that people aren't coming back to the hospital when they don't particularly need to, because you're right, who wants to be in a joint like this? Well, it's true. You don't really want to be here. I think we forget that. Much rather be at home with your family, wouldn't you? Watching the footy or something. So just in terms of practical things we can do, we spend a lot of time in this institution trying to track down medical treatment decision makers and filling it into the EMR because the government say we should do it. Wouldn't it be better if we spent time finding out who the patient's principal carer was and putting them into the care team on the storyboard, so every clinician who was involved with them thought about the carer every time they opened the EMR, and or put the carer up on the whiteboard in the inpatient setting? I know it's all PR, but really it's trying to change the dynamic around from where it is now to you should be thinking about the carer just as much. Because when you made that comment before, Gail, about it's hard to, while you were talking, you said that the mind shift for practitioners from the patient focus to a carer, or to include the carers. I had a little sort of heart attack because I have enough trouble getting the doctors to think about the patients instead of just their cancer. But yeah, I get it. I think it is about trying to shift that whole mindset. It's not the only answer. It's just part of what I think we need to be doing. We need to make things just like we need to utilise the resources best we can. We've got an EMR, we've got all these things. I think we need to think about using them better. I'd much rather that the carer was in there than a whole lot of the other stuff we spend time and energy on. Good. Can I jump back to a question if there's no one else in the audience for a sec? Oh, pardon me.
Sorry.
Go ahead.
My name is Kathy. I'm a ward clerk in the palliative care ward. And I just want to say on that, what you're talking about, David, we have a section in IPM for primary carer. And we're never instructed to fill that out. So I think that's a first step. We do the medical treatment decision maker, all of the other contacts, but that one is not one that's noted to be. And I think that's something that we could probably use. I don't know how that transfers through to Epic. I don't think it does sit there, but
Well, there are clever people who can fix it.
There could be someone who could connect that. It just could be a tool that we could use a bit more.
I think you're absolutely right. We might just, there's a little bit of time. This is a great question here about, I've found support in workplaces as a carer very difficult, even to the extent I would be judged poorly because I'm caring for my loved one. Know any of the supports that could be given to employers, to workplaces, to try and make life a bit easier for carers? Do we have any documentation and resources that carers might be able to use, or is that something we should be developing? Gail, don't know if you've seen anything like that in the UK.
There's an increasing recognition in the UK of carers in the workplace, but I think that seems to operate between the organisation and the individual carer. I'm not aware of anything specific within the hospice or hospital organisations. Again, it's something that comes up in the conversations with carers, issues around work, because again, that's another question on the CESNAT, but I'm not au fait with the situation in the UK, I'm sorry to say.
I think there's not necessarily a lot of services I'm aware of that can help the actual employer work out how they can support carers, but I think sometimes it's as simple as remembering, like we've said with everything, remembering the carer as part of conversations and assessments and saying, do you need a certificate for work? And just checking, because if they have something on letterhead from Peter Mac saying people need to take leave, generally it's a lot easier for people to get the support they need and the care they need. So even if a carer is not there with the patient in an appointment, it's those kind of things of saying, is someone caring for you that might need a certificate or that might need some additional support with work, and looking at things like referrals to look at different financial support options and things like that to help support people. But it is really tricky because they're doing this, 2 full-time jobs essentially often, and so it's a lot to expect of anyone, and it's not something we would expect of ourselves. And so it's remembering that too, that that we should afford people that opportunity to access that support that anyone would need in that situation.
Actually, speaking from personal experience, I would just recommend that people have a talk to their employers and also keep them updated with the changes, because as the conditions get worse and you need to disappear from work more quickly or whatever, it's useful to give employers that heads up so that it doesn't come as a surprise, and then they can better support you. So in my case, for example, I kept my employer quite regularly updated. I mean, mind you, sometimes they still rang me while I was in the hospital, and I would be doing laps around the hospital, taking work calls. But but it is useful to have that conversation up front and let them know where the situation is at, so that they can support you.
So it might be something practical we can do. I just want to sneak in one more question, which Jared, which is really about any comments from the panel about confidentiality and conflict between carers and patients, and how you might, is that an issue you see? I suppose particularly the confidentiality thing. Any challenges you've seen in that area?
I guess in my role as a psychologist working with carers, we see it as really important that the carer notes are separate and private. So in our situation, we've created a separate medical record for the carer, so that their psychological treatment notes are in an entirely separate place and separate to the treating team and separate to the patient. But that's been something that's been a challenge for our program, and I'm not sure about what others think in their work.
I think it's always a challenge for us, because there's lots of conversations we're having with carers that aren't, shouldn't be part of the patient's record, or there might be family violence concerns that we need to be obviously sensitive about how we document that. But there is a tab in Epic that we put sensitive encounters in place, which basically people have to break the glass or go in and put a password in to actually access those notes. And that means that if there's an FOI request and people are asking for their notes, they're not released with that as well. So that's kind of a workaround what we've had, but it is something that we have to consider, and it is a common concern for carers if we're going to be talking to patients about what we've discussed, because we're often seeing carers and patients, and so it's important that we're upfront with with those conversations and letting people know that we won't be sharing that information, and not assuming that our carers will think that or know that, and being really clear in our communication around the confidentiality aspect of things.
Thanks. Now there are a couple of things mentioned on the net, which I'm going to finish in a minute because we're over time, of resources that are around. I'll mention them in just one second. I want to thank the panel. I don't want to chuck up the idea, because we've talked about this, just about patient, should a carer have their own record? So I just want to throw out a hand grenade. I actually think because carers are working, maybe what we should actually get for carers is a HR file, because they're really employees. Anyway, that'll stir Sean Curtin up a lot. But interesting idea, because I've sort of been very resistant to the idea of creating a patient record for a carer. But actually, when you look at all the things we've been talking about, a HR file is probably not a bad idea. Anyway, there are some fantastic resources out there for carers. One is called AI and Non-Family Groups, been in Australia for over 70 years. A couple of people have mentioned that. Another one is the Victorian Support for Carers program. Works through 63 providers around the state. So there is stuff out there, and I'm sure we'll get all those wonderful things you've mentioned online, will get put into a document and send around to everyone. Really want to thank Gail Ewing for coming out, not just for her presentation, but for her contribution to the panel, and for spending so much time in Australia and helping us out. To all our panel, thank you very much. And to all of you, if you're here in the room or online, really appreciate your time, and sorry we have to finish in a hurry, but I'm running late as usual.